record on this. Awesome. Thank you so much. Without further ado, let's begin. So let's see, where are we? There we go. Cool. All right, it works. All right, I'm as you can see, very excited. Any of you who have been to Chicago and have ever visited the now Willis but formerly Sears Tower may have stepped out onto the ledge and jumped. And so today, hopefully we won't be quite that scared about salivary biopsies, but I thought this was a fun little activity that we did not too long ago. Anyway, as you can see here, I'm using the Path Presenter format to present you some PowerPoint slides as well as some virtual slides. And so you heard I'm very interested in digital pathology. So we're going to do a lot of virtual slides in this lecture. I hope that you feel comfortable piping up with your comments in the chat. I also have some polls. When the polls are active, I will certainly speak that out, but I'm going to put in the chat the link to the presentation where you can respond to the polls on each of the respective slides. So hopefully that will work. So we're going to go over a clinically relevant approach to salivary neoplasms, starting usually with a core or a shave biopsy, followed up by a resection and occasionally with genetics and immunostains, certainly. Just as kind of a very broad strokes overview, salivary neoplasms, of course, more often than not are benign, right? Pleomorphic adenoma, of course, being the most common tumor, the most common benign tumor, the most common malignant being mucoep. And then interestingly, the site with the highest rate of malignancies is actually the sublingual gland. But mostly in this course today, we're going to be dealing sort of with parotid, a little bit with palate as well. So as we know, sort of biopsy is a mainstay of screening. Generally, at least in the US, it comes in the form of an FNA biopsy for, palpable masses in and around the parotid area. And so the Milan system, has been proposed as a way to risk stratify patients, not only for sort of risk of neoplasia, but also risk of malignancy. And so depending on what the biopsy shows, people may undergo clinical follow-up, repeat FNA, but definitive treatment for salivary neoplasms is certainly surgical, whether it be a benign tumor or a malignant tumor. So how does core biopsy come into play along with FNA? So there's actually quite a number of studies putting core biopsy FNA head to head. And interestingly, a lot of the studies have showed that there may be increased rates of just diagnostic tissue with the core biopsy, as opposed to higher risk of non-diagnostic in an FNA. There may be higher sensitivity as well as specificity for diagnosis of subtypes of malignancy with a core biopsy. And what we have found as well is that, certainly the ability to perform immunostains is enhanced by having a nice larger tissue chunk, such as on a good core, or even in the case of a cell block from an FNA. And so, immunostains aren't going to help you in all circumstances, but they may fine tune your diagnosis in some cases. And hopefully you'll see how that works in this lecture. All right, so once a lesion is thought to be a salivary neoplasm, it's helpful to determine whether it's primary parotid or metastasis to parotid. As you know, there are, I guess I should rephrase that, any of the salivary regions, right? Parotid, submandibular, both have lymph nodes sort of in and around the glandular parenchyma. So there can certainly be tumors that arise in the parotid tissue, as well as those that metastasize to intra and periglandular lymph nodes. So if a primary parotid neoplasm is defined as benign, even if it's defined as a low-grade malignancy, generally these undergo the same treatment, which is resection with negative margins and follow-up observation. So because the treatment of benign and low-grade malignancy is usually quite similar, I would argue that there is almost no need to make a very specific subclassification biopsy, a subclassification diagnosis on biopsy. And we often say things like low-grade salivary neoplasm, here's your differential, or if it's high grade, it's very important to state that it's a high grade malignancy or high-grade carcinoma, because then these patients not only will undergo probably a bit wider of a resection, but also post-operative chemoradiation and intraoperative neck dissection, usually at least ipsilateral neck dissection for the side of the high-grade malignancy. Now, if it's a metastasis, things we like to think about, certainly most commonly, at least in the parotid region, are cutaneous. So squamous of skin, melanoma of skin, et cetera. Treatment in these cases will certainly depend on the overall disease status of the patient. So hopefully that gives that's an overview of how I like to broad framework these neoplasms. So once the decision then is made to operate based on your biopsy or FNA diagnosis of low grade, resect, high grade, resect with a neck or something else, we certainly again want to confirm whether this is a primary salivary tumor or a metastasis, confirm again the histologic grade, generally low versus high. There are not established formal grading systems for all salivary carcinomas, but common sense will dictate that things like perineural lymphovascular invasion, necrosis, high mitotic rate, pleomorphism are things to look for in high-grade malignancies. Giving a diagnosis of intermediate grade is generally not helpful to our clinical and surgical colleagues, because that's very hard for them to understand whether to treat as a low grade or to give adjuvant chemoradiation as a high grade. So we really try to help them sort of push these tumors into one or the other. The exception of a grade might be in some tumors like adenoid cystic that generally uniformly have some ancillary treatment, or tumors that have targetable mutations might undergo targeted therapy, NTRK, et cetera. Certainly we'll comment on margin status, and certainly we'll give a TNM stage if a malignant diagnosis is made. Okay, so my approach to salivary tumors is as follows. Sort of examine the border, which of course is best done on a resection specimen. If you're getting a core biopsy, that's nearly out, right? Circumscription is a great indicator of benign or generally low-grade malignancy, but both benign and malignant can be circumscribed. Infiltration is certainly the best indicator of malignancy in salivary gland neoplasms. I like to examine the number of cell types, whether that be generally 1 or 2. So, formally, monomorphic, quote unquote, adenoma, right? Monomorphic salivary gland tumors can be composed of purely epithelial cells, or for example, purely myoepithelial or basal cells. And then there are the biphasic tumors that are composed generally of both epithelial and myoepithelial / basal cells. And we'll see these examples as we go through. We're going to be also examining the general morphologic pattern, more of a basaloid cribriform tubular pattern, a cystic secretory mucinous pattern, a solid or nested pattern, and then an oncocytoid or an oncocytic pattern. And, I like to, pretend that things are quite simple like this, but in fact, many tumors can fall into many of these categories, depending on what morphology they manifest, what time of day it is, whether there's daylight savings time. No, just kidding. But really, many tumors fall into many categories, and this is a little bit of a simplistic view. But I like to let H&E certainly be our guide with selective use of immunohistochemistry and genetics. And so I don't know if Katie's on this call, but our former fellow Katie Higgins and I wrote a recent paper, a review of immunohistochemistry and select use of genetic testing in myoepithelial, in salivary gland tumors. I have a link to the paper later on in the lecture, but essentially, if you think about these morphologic pattern groups, epithelial, biphasic, purely myoepithelial, oncocytic or oncocytoid, secretory, basaloid, solid, you can pretty much cluster tumors in these categories, and using immunohistochemistry to determine whether something is of myoepithelial and epithelial, so-called biphasic phenotype, can really narrow your differential, and whether it's monomorphic into one of these boxes can also sort of really push you into one box or another. So we're going to go through these sort of differentials throughout the lecture, but hopefully this chart you can refer to as needed. All right, so virtual slide, awesome. So as I said, most of this lecture is going to be virtual slides, and here we begin. So I would love this to be a little bit interactive. So if you guys want to pipe up with your comments, etc., in the chat, please do. So this is, as you can see, a core biopsy. I always like to look at the neighborhood, right? What's going on in the surroundings? And here in the surroundings, we have some purely serous salivary tissue with some ducts, so likely parotid. All right, so if we're dealing with serum mucinous, we may be more likely to be in the submandibular, etc. Okay, so moving on to the lesion, you can see that there's a little bit of a clean border between the tumor and the parotid. Certainly, you've only sampled a fraction of the border, right? But if you look, the background stroma is very pale, very mucinous, or at least myxoid, and there are these strands of cells within the myxoid background. And so, it's very paucicellular. It's myxoid background. Then is it epithelial, myoepithelial, or both? And so if you look carefully, you may start to see some duct-like structures, right, with some pale pink eosinophilic epithelial cells, perhaps with a more peripheral layer of bluer cells. So you get perhaps a vague suggestion that there may be some ducts in here. However, the background is mostly these corded, arguably myoepithelial cells. And so in the absence of any immunohistochemistry, what is the least we could say? Well, the least I could say about this is it seems to be a paucicellular, very cytologically bland, therefore low-grade salivary type neoplasm. Okay, so on this type of biopsy, very low-grade paucicellular salivary type neoplasm might be the most you give. If anybody wants to favor a diagnosis, maybe you'll favor what this is, right, which is a pleomorphic adenoma, right? So this is probably one of the more straightforward cases where you have that diagnostic myxoid stroma. One can argue, well, if these cells are myoepithelial and there's myxoid stroma, why is this not a myoepithelioma? And some might argue, well, there are occasional eosinophilic epithelial cells forming ducts. So the presence of any duct type of structures will then push this into a pleomorphic adenoma, right, which is biphasic. And so some people might disregard the focal ducts and say, nope, it's a myoepithelioma. Some might regard the focal ducts and say, yes, it's a pleomorphic adenoma. I'm one of the people that regards the ducts as neoplastic and says, yes, this is a pleomorphic adenoma. So that's diagnosis on case one. Not too challenging, but just an example of a common finding. All right, case two, I will tell you, is also in the parotid, even though we don't have any background parotid tissue. And I believe there may be a poll. Yes, there is a poll for this one. So if you guys would like to pull up that link in the chat, I don't know if you can copy and paste it, or if there's a better way for me to get that link to you, but it's in the chat. And if you'd like to participate in the poll, please go ahead. Otherwise, please type your differential diagnosis into the actual chat. So this is not paucicellular, right? This is quite cellular. Looking at the actual cytomorphology of the cells, the nuclei are oval. There's some scant pink cytoplasm. Not really many mitoses, no necrosis. So still appears, even though cellular, perhaps low cytologic grade. Then do we see one cell type, two cell types? This is a little bit hard, right? It's not very clear if there are ducts or if these are all a monotypic population. And so in this case, immunohistochemical stains may be helpful for us to at least know whether this is monomorphic or biphasic, okay? Again, please type your comments in if you have them. So the next stain here is going to be, I like to demonstrate the presence of, first, the presence of any significant myoepithelial component. And generally the first step I take towards that is something like a P63 or a P40. And we'll get into why P40 is much more specific than P63 when it comes to certain types of tumors, but this is a P40, okay? So you can see that there are certainly P40 positive myoepithelial / basal cells, And there is a negative population, right? There is a population of cells that where the nuclei are not staining for P40 and a significant population where they are. So one is probably now in at least the category of a biphasic neoplasm. The next stain I like to pursue is c-KIT. And so you might think c-KIT, is she thinking adenoid cystic? Like, why is she doing c-KIT? Well, interestingly, c-KIT stains the epithelial component of many salivary tumors, not just adenoid cystic, right? So in this case, you can see small nests almost forming tubule-like structures that show nice membranous c-KIT expression, and the remaining cells are negative. So we can almost assume, if you map them side by side, that the c-KIT positive population is perhaps the P40 negative population, and the P40 population, P40 positive is the c-KIT negative. So we appear to have a biphasic salivary neoplasm, if you believe me, okay? What else might you want to see? Sometimes certain salivary tumors express strongly and diffusely S100. That's a whole different ball game that we'll get into as well. So sometimes we throw on an S100 to see the extent of staining. In this case, not really much. So we're dealing with a histologically, at least cytologically bland, but cellular biphasic neoplasm. So honestly, at this point, that's kind of where we are. Once we have a resection, okay, maybe the diagnosis will become clearer. And so focally, only very, very focally, is that characteristic myxoid myxochondroid stroma with some perhaps hyaline plasmacytoid myoepithelial cells that may make you think of, yes, pleomorphic adenoma, all right? And so in this case, the core biopsy got mostly the cellular area, but did catch some of these ducts, right? And so we can say it's biphasic, we can say it's low grade, and then when the resection comes out, it appears quite circumscribed, right, with very focal myxoid areas, but overall very cellular, quote unquote, cellular pleomorphic adenoma. And now you can perhaps maintain these ducts here. So when we think about, biphasic neoplasms, what comes in? I'm going to type stuff in the chat, right? What comes into mind? Pleomorphic adenoma, adenoid cystic carcinoma, epithelial myoepithelial carcinoma are ones, right? What else? Even perhaps some might argue basal cell neoplasms. So if you're thinking, probably the nearest thing on the differential for this case might be an epithelial myoepithelial carcinoma, because it doesn't quite have the morphology, right, of adenoid cystic or even of a basal cell neoplasm. I would probably argue that in light of the circumscription, the low histologic grade, and the focal sort of myxoid myxochondroid areas, that I would favor this to be a pleomorphic adenoma as opposed to a circumscribed epithelial myoepithelial carcinoma. But if you have alternate thoughts, I'm very happy to hear them, because these can be challenging cases. All right, questions or comments? I see nothing in the chat. Myoepithelial predominant PA. Okay, great, excellent. We have at least one concurrent thought. Yeah, so quote unquote cellular pleomorphic adenoma or myoepithelial rich pleomorphic adenoma are terms that can be applied to these type of cases. I was asked the question once, well, what does that mean, or when do you use that? And reading the literature, right, there's not a great consensus on when you call something cellular. Like, if you want to get the point across to your pathology colleagues, next time this recurs, and it recurs as a highly cellular neoplasm, you might call it a cellular / myoepithelial rich PA. What if it's EMCX? How do you distinguish? So, generally, for carcinomas X, I like to have an overt invasive component. And so, I remember, years and years ago, considering, or at least considering diagnosing, I think we maybe even did a very tiny focus of mucoepidermoid carcinoma in the center of a otherwise circumscribed pleomorphic adenoma that you might call like mucoep in situ XPA. Well, what does that really mean? Like, Could it really just be mucinous metaplasia within a pleomorphic adenoma? Probably. If you don't have an invasive component, as I would argue you do not in this case, whether you diagnose, if you diagnose carcinoma in this context, you must diagnose it as in situ or intracapsular. And therefore, the clinical behavior is basically the same as a benign pleomorphic adenoma. And so honestly, I don't think this is Epi-MyoEp X because it does not have an invasive component. We know that the morphology can be overlapping and it's overall very bland or very low grade. And so in this case, I would not diagnose an invasive carcinoma X. I probably would not even diagnose an in situ or an intracapsular carcinoma X. If you think that's what it is, again, I would be very cautious and explain that this is still a circumscribed neoplasm and indolent behavior is still expected. And yes, so I'll give you tables on mutations in a bit. And so HRAS mutations are present in Epi-MyoEp de novo, but generally Epi-MyoEps X still retain the plaid type of rearrangements that you see in pleomorphic adenoma. So I would argue that for pleomorphic adenoma and pleomorphic and carcinomas X, the genetics generally tend to be the same. So the genetics are less helpful in distinguishing benign from carcinoma X. To me, it's more the morphology. And this doesn't have, as I said, that infiltrative morphology. You can use Ki-67. I don't. I tend to think that actually looking for mitoses is better because we don't have standard ways of evaluating Ki-67 in salivary neoplasms like we do for other, neuroendocrine neoplasms. So I look for mitoses and I look for necrosis as potential indicators, of badness. But in this case, obviously there's none. Hopefully that was helpful. Okay. So moving on to, you're welcome. Moving on to the next case. I think there might be a poll in this one as well. So again, there's really no surroundings, but we're still on the parotid, okay? This case has also some myxoid stroma, also some cords of cells. It's a little bit hard for me at this point to tell whether this is monophasic or biphasic. Oh, there's maybe a duct right there. There's another sort of strand of ducts. There's a duct. Does anybody have any thoughts? Otherwise, I'll just move on to the immunostains, right? So you'll start to see a pattern here in my approach to the immunostains. One, does it have two cell types? In this case, I'm showing you P63, which would be the equivalent in this case of P63P40. Liam has an adenoid cystic going on in there. And in fact, there is a P63/P40 positive population and a negative population. So this is a biphasic neoplasm. We're going to move on to c-KIT. All right, so we saw that c-KIT highlighted the epithelial cells of that pleomorphic adenoma. And in fact, it also highlights the epithelial ducts of this tumor. We can try out a myoepithelial marker like an SMA to see if it highlights very significantly any of those myoepithelial cells. In fact, it doesn't. So, when you think about myoepithelial cells or / basal cells of salivary, these in the neoplastic state, myoepithelial / basal cells can be quite challenging and quite immunophenotypically diverse, right? And so if they express contractile apparati, they may have SMA or calponin. If they don't, they may just be P40, right? And so we're dealing with a very heterogeneous phenotype of these myoepithelial / basal cell population. What do I have here next? Yep, I think that was, I actually think I misspoke. I actually think this one was S100. Not SMA, sorry guys. This is SMA. I have my little cheat sheet here on my left. This is SMA that again is sort of variably sort of weak to moderately strong in some of the myoepithelial cells. But it's a little bit, to me, it's a little bit less clear than the P63, P40 because this is a cytoplasmic, of course, rather than a nuclear marker. So again, a little bit heterogeneous, but there's some contractile marker expression. So we have another vote for adenoid cystic. And those of you who said adenoid cystic, in fact, would be completely correct. And so this is an adenoid cystic that has a biphasic architecture that could certainly mimic a pleomorphic adenoma on biopsy with that biphasic phenotype with the myxoid stroma. But I think some of you got a sense, right, that there was maybe a little more cribriform architecture, that maybe the nuclei were a little bit more wrinkled like you tend to see in adenoid cystic. Exactly. And so at least raising the possibility of adenoid cystic on core biopsy would be useful clinically. And this is the resection, which in fact shows much more characteristic cribriforming and you can see at the periphery, excuse me, and oops, my mouse is going the wrong way than I think, an infiltrative growth pattern here, sending these nests way out into the periphery next to these large nerves. So yes, in fact, adenoid cystic is the correct answer here. So on core biopsy, one might say biphasic salivary type neoplasm. Differential diagnosis includes a pleomorphic adenoma with cribriform structures. However, adenoid cystic is certainly not to be excluded. If you feel very comfortable with adenoid cystic on the core, you certainly could say that. However, I would caution you that some pleomorphic adenomas do also or can also contain cribriform-like spaces. And so that for these reasons, I'm actually quite cautious on core biopsy with giving a definitive diagnosis because I think it's best considered on the resection. I mean, you guys were great. You got it already. And so I don't know if you need to see or want to see the stains, but just to confirm on the resection, it's a little bit paler, but again, you have your P40, P63 positive. There's a nice couple of ducts right at the periphery, and your c-KIT positive sort of epithelial cells, right? So this sort of sandwich of epithelial and myoepithelial cells in this geographic distribution is very helpful. Okay, moving on. Questions on that guy? Awesome, well done. All right, so the next is one of my favorites because I don't think we see it very often, although I think we've seen a few in the past year that have been really exciting because we've got to reiterate this diagnosis. But looking in the surroundings, we have some serous parotid tissue as well. And we have, again, a very, very cellular core. So this cellular core has sort of some tubules and ducts. It has these large, almost nests. You start to see, rather than a very myxoid stroma, you start to see these like pink little bands. What else do you start to see? Yeah, you perhaps also start to see more pale little globules. So you could start to think, well, is this cribriform space in an adenoid cystic, or what else could these little sort of small tight globules represent? But regardless, you see a quite cellular salivary neoplasm with these little globules. And let's take the same approach because I like this approach. So let's start with a P40. So a P40, I think there might be a pole in here. Nope, no pole. Okay. A P40 shows a P40 positive layer and a P40 negative, presumably epithelial layer, right? So that biphasic geographic distribution of positive and negative. Because we're taking the same approach, let's do a c-KIT. And in this case, it's focally helpful. You focally see these duct-like structures. Okay, all right. So we're thinking this is something biphasic or biphenotypic. I guess I shouldn't use the word biphenotypic because that seems a little more like the salivary, the sinonasal tumors, right? Okay, and then let's move on to our classic S100. So in this case, I'll point out that S100 is predominantly negative in both what we think might be epithelial and myoepithelial / basal cells of this tumor. But what it does highlight are these kind of spindly cells in strips between the cellular nests, right? So this is starting to imply something to me in addition to the morphology. So S100 is really highlighting that spindled stroma. So can you guess? Yeah, somebody already got it, exactly. So if you're thinking it's basal cell adenoma, which you're correct about, what stain might this be? It's a little challenging to interpret because it's like positive everywhere, but this is beta-catenin. So in basal cell adenomas, not really so much basal cell adenocarcinomas, but basal cell adenomas have beta-catenin mutations. And so they have shifted their localization from beta-catenin on the membrane to the cytoplasm and the nucleus. So you can see that in many of these cells, you have pretty significant nuclear expression of beta-catenin. I'll show you later on what normal membranous pattern looks like. But this is beta-catenin. So this is quite good for a basal cell neoplasm, most specifically a basal cell adenoma. So S100 in spindle cells of BCA, yeah, I think is quite good. And if you are careful about interpreting the location of the S100 positivity, you will see that it very, very strongly highlights that spindled stroma, as you can see here. And so if we go back, let's see if we can go back to the H&E and find that area. So I've been using it. Because I think it's very good. And so it's these, let me see if I can annotate. It's like these areas here, right? In between the glands that are strongly positive for S100. So if you can demonstrate that, but based on your comparison of your H&E to your S100, I find it quite helpful, as well as then the beta-catenin to show localization to very strongly within the cytoplasm, but more specifically within the nuclei. So hopefully that was helpful. So you could call this a basal cell neoplasm, low grade, favor basal cell adenoma because of the beta-catenin, because as I said, beta-catenin really shouldn't be positive in the basal cell adenocarcinomas, but always caution on core biopsy. Sometimes our surgeons send frozens, and mostly that's to demonstrate basically low grade from high grade. They don't care so much about the subtype diagnosis, but if you're going to say this is a low grade salivary type neoplasm that I do not think is adenoid cystic, they're basically going to say, thanks, I'm done. If you're going to say, oops, this is looking high grade, or this is looking like a potential adenoid cystic, they may go do a neck dissection, okay? And so this is a frozen of that case, just sort of showing you, there does appear to be a thin capsule. There appears to be a little like pooch into the capsule, right? But not transcapsular invasion. And so low-grade salivary neoplasm in this case would be adequate. Here's the resection specimen, very circumscribed. And again, showing you that so-called tubulotrabecular architecture of a basal cell adenoma with very characteristic, very brightly eosinophilic hyaline stromal material. So these stromal bands can either occur between the nests or within the nests as little globules. So that's a good feature for basal cell adenoma. And as you noted, here it is. Here's that very cellular spindled stroma that would be positive for S100. And I think this is quite characteristic, and I like to use this combination of the tubulotrabecular, the eosinophilic globules, and the stroma together to make a diagnosis of basal cell adenoma. And I think this is very characteristic. And so in contrast, I just wanted to show you an example of a very similar neoplasm that was also sent for frozen, as you can see here. Also shows this sort of tubulotrabecular, perhaps now moving into a so-called membranous pattern, meaning like this jigsaw puzzle where you almost start to look like a cylindroma of the skin, where you again see these hyaline eosinophilic stromal globules. And one thing I will point out is that also your cytomorphology is still arguably bland, still ovoid, not hyperchromatic, not mitotically active, all right? So probably still something low grade. But if you look at the periphery, what do you see here? You see these nests that infiltrate and jump, right? Now you have tumor, normal, tumor, tumor, right? So this is now infiltrative. So you could still call this a low-grade salivary neoplasm, perhaps favor low-grade basal cell adenocarcinoma on frozen. And in fact, your permanent sections will concur with that diagnosis where you have this infiltrative pattern along the duct, but you still have this tubulotrabecular and membranous architecture, again, with low-grade cytology. So this would still be a low-grade neoplasm, but a low-grade basal cell adenocarcinoma. And just to confirm with our panel of immunos, again, we have P40 to show that basal/myoepithelial cell component. We still have c-KIT. In this case, it's not quite as clean, but you may see some epithelial cells that are staining. And importantly, what I wanted to show you here was that beta-catenin, right? So in this case, the beta-catenin is completely membranous like a crayon. You don't have that nuclear or cytoplasmic expression. And one additional marker that has been sometimes used in basal cell neoplasms is LEF1. So this is LEF1, as you can see, nuclear. But I don't really use it as specifically because it also stains nuclei of other neoplasms like pleomorphic adenoma or other biphasic things that are in your differential. So unfortunately, I do not think LEF1 is quite as specific. I do think beta-catenin is good for basal cell adenomas, but not for basal cell adenocarcinomas. And LEF1, I don't like. Does that make sense? Okay. I did want to show you a picture of an epithelial myoepithelial carcinoma since we didn't have one in there to flesh out the biphasic neoplasm spectrum. Generally these tend to have very clear myoepithelial cells that stain with your both your basal and your myeloid markers as seen here with SMA. The reason why I tend to use c-KIT as opposed to a CK7 or a low molecular weight keratin like CAM is because CK7 or CAM will stain both the epithelial and the myoepithelial. So in this case, the epithelial is stronger and the myoepithelial is weaker. But I tend to think that interestingly, c-KIT is a little bit cleaner. It stains the epithelial more strongly and really not the myoepithelial or basal really at all in most of these cases. So that's why I use c-KIT instead of like a CK7 or a CAM, but it's all possible. So when you're dealing with these biphasic neoplasms, both of them have epithelial, myoepithelial/basal population. So I would argue morphology, and in some cases, genetics could be helpful. Okay, you can see here, you guys asked already about RAS. Again, that applies to mostly the de novo cases. And you can see the genetics that might be helpful for you here in the table. But since we're low on time, I won't belabor it. I won't belabor those. Okay, questions or comments before moving on to the next category? Okay, so now we move from core biopsy of parotid to shave biopsy of palate. So in this case, you could see squamous mucosa at the top, and then you can see a very cellular neoplasm below. If you choose to take the poll, you can, or you can type something in the comments, okay? And so we want to sort of look around and see, do we see any obvious epithelial, myoepithelial bilayered structures on H&E? We certainly see these sort of duct-like structures, but I don't see any obvious peripheral basal or myoepithelial cell layers. All right, so you may want to start in the same vein, okay? You may want to start with a P63, P40. In this case, we're going to go straight to the big guns. We're going to go straight to P40 because, as I said, it is more specific and it's completely negative. All right, P40 completely negative will basically put you in a not biphasic category. All right, so a not biphasic category, you may want to then think about S100 because there are a few monomorphic neoplasms that are diffusely strongly S100 positive. So this is S100. And in case you're asking what the diagnosis is or if I've done mammoglobin, I can tell you that mammoglobin is negative. Okay, and so this diagnosis was made as a polymorphous adenocarcinoma. Okay, so the interesting thing about polymorphous is that it can be P63 positive, but it's completely P40 negative. So don't please just do a P63 and call it a day, because you'll go down the wrong path and say, oh, this is a pleomorphic adenoma when it is in fact not. And so I love P40 for this differential diagnosis. And so all of these on this page, the monomorphic neoplasms are P40 negative. That's with the exception of like an intraductal carcinoma that is theoretically contained within a duct, so it'll have that P40, P63 positive outer layer. But as you can see, many of these are diffusely strongly positive for S100. Only a couple, including of course secretory, are positive for mammoglobin. And between the P40, the S100, and the mammoglobin and the morphology, you can sort of come to a differential diagnosis. In this case, the morphology is very good. The location, very good for polymorphous. Remember, it's no longer PLGA. It's no longer polymorphous low grade. It's polymorphous, comma, give a grade, right? Because these could be low and these could be high. This is certainly a morphologically low grade neoplasm. So this is a polymorphous of palate P40. P40 is your friend. Okay. The next case is an interesting case of a parapharyngeal space mass. And so what they did is they went in the oral cavity and they tried to go through the base of tongue, like to the parapharyngeal space. And so this is what we got on their diagnostic, or theoretically diagnostic biopsy of parapharyngeal space mass. So you basically see some minor salivary glands and some lymphoid stroma, probably from the base of tongue. I'm just going to tell you this is completely non-diagnostic, right? So don't ever give up. Don't ever give up. This non-diagnostic biopsy resulted in, well, the surgeons being like, well, that's not right because this is the mass. Okay, this was the mass that came out of the parapharyngeal space. Oops, we just didn't get it through the base of tongue, but it's certainly large and heterogeneous with some hemorrhage, with some sort of yellow, almost gelatinous-like areas. All right, so yeah, that's the tumor that came out of the parapharyngeal space because they didn't have a diagnosis at all from the core biopsy or the chunky biopsy. They froze it, okay? And again, we see some bland ovoid cells with some intranuclear, maybe artifactual kind of little vacuoles. Do we see any overt bilayered ducts? Hard to say because it's a frozen, but I certainly see little kind of duct-like or cystic spaces. If anybody wants to throw out, our differential in the chat, please feel free. Otherwise, I will just move on. So this was called a low-grade salivary neoplasm. The person at the time of frozen favored this to be a pleomorphic adenoma. Probably because that's the most common tumor that we see. However, here we go. So here's the H&E, again, showing these variably cellular areas with some microcystic mucoid spaces with some duct-like structures, but I would argue that I do not see a squashed layer at the base of some of these duct-like structures. So are they really bilayered ducts? Is it a PA? Well, let's see what our stains show. All right. So here is your P63. And this is what I'm trying to get at. All right. So, hey, P63 positive. Cool. It's biphasic. Well, here's your P40. All right. So very drastically different. P40 does not really highlight any myoepithelial or basal cell layer in this neoplasm, whereas the P63 was really wackily strong, right? So this is why P63 is not specific and P40 is. So I think you can see where I'm going with this, okay? So this is a C-kit, which if it's not a biphasic neoplasm, if you don't have P40, then your C-kit can do whatever it wants. Like, okay, it's staining some of these cells, it's not staining others. I'm just gonna kind of disregard the C-kit because it's not gonna be helpful for us. But what might be helpful for us here is, yep, you might have guessed it, S100, diffusely strongly positive, and you may want mammoglobin, few cells here and there, nothing really going on. So do you guys have a diagnosis in this large parapharyngeal space mass? Before I give the big genetic reveal. All right, so we like to do next-gen sequencing on a lot of our tumors because we think it's interesting, and it is, in this case, at least very helpful diagnostically. And so this had an arid PRKD1 fusion. PRKD is fused in specifically the quote-unquote cribiform variant of polymorphous adenocarcinoma. PRKD1 is mutated in the conventional palatal polymorphous low-grade adenocarcinoma. So this is probably a spectrum of PRKD1 related neoplasms, okay, in which the conventional polymorphous is mutated. The cribriform variant is fused. And interestingly, the ones that are off the palate that have the PRKD fusions tend, even though they appear histologically low grade, tend to have higher rates of lymph node metastasis. And so in fact, this guy did have a neck dissection subsequent to the diagnosis on the original, and he did have multiple positive nodes, even though they were clinically inapparent. So just a word of caution on the specific cribriform variant, right? So outside of the palate, generally PRKD fused, generally lymph node mets, okay? So hopefully that was helpful to show those various types of neoplasms. We don't have an acidic here in this class, but you know, we can talk about it later if you want. But here's that chart of overview for your reference, should you choose to refer to it. This is, again, that chart of basaloid. I'm going to just skip right over it so you can review it on your own because you all have the link. All right, so again, in the sake of time, I did want to just show you on this one slide, we have a pleomorphic adenoma on the left and a basal cell adenoma on the right. You can see how the beta-catenin is actually nice in the nucleus of the basal cell adenoma, but you can see how the LEF1 is both in the nuclei of the basal cell and the pleomorphic. So again, why I don't really like the LEF1. Okay, we're just going to skip over these guys. All right, so our next, if you guys don't have any questions or comments, I'm just going to keep moving because we have a few more cases left, but I'll get through them. All right, hopefully this is being helpful to show you sort of my thought process of workup rather than, you know, just a simple PowerPoint didactic, but you'll give me your feedback later. Okay, so another shaved biopsy of palate. Again, showing some, you know, salivary gland of palate, mostly mucinous, and now showing this sort of circumscribed lesion amidst the salivary glands. So, you know, as we said before, invasion is always helpful for malignant, but both benign and malignant can be circumscribed, right? So let's see what's going on with this. Sort of similar to the prior, where we have these ductal or tubular-like structures, where we have this very watery secretory material, okay? We don't see an obvious, you know, bilayered ducts. We do see ovoid sort of bland cells with maybe some small nuclei. Yeah, great. So secretory carcinoma, right? So let's just jump to our pattern, right? So here's what is this? P40. So I don't know, there's like 2 cells here and there, but really nothing that's that geographic distribution of you know, inner epithelial, outer myoepithelial, right? So that's not happening here, P40 negative. What do you think is next? S100, right? You see my pattern. And your favorite, mammoglobin, all right? So now we're in certainly the category of a secretory carcinoma. You can see nicely on the mammoglobin how maybe there's like a little bit of maybe a couple of nests that infiltrate here, but really overall an extremely circumscribed lesion. So yes, a low-grade neoplasm, but a carcinoma, even though it's quite circumscribed. I'm sure you all know the ETV6 and TRAC3 rearrangements, right, that happen in secretory carcinomas, regardless of whether they occur in the salivary gland, in the breast, in the thyroid, right? They're all morphologically and genetically the same. But just remember, just like any other neoplasm, you will always want to evaluate for high-grade features such as necrosis, increased mitoses, PNI, LVI, right? Because this is what's going to pop you into the high-grade category and by the patient a neck dissection and by the patient chemoradiation, okay? Of these tumors here that are sort of cystic or secretory or myxoidy, you know, really mucoep is the only one that is diffusely positive for P63 and P40 because the intermediate and the squamoid cells in mucoep all express P63, P40. And so I find that when you have a strongly P63, P40 expressing neoplasm, you're really probably not dealing, I mean, let me rephrase that. Your differential is narrowed, right? Out of these into a potential mucoep. So, okay, let's move on again for the sake of time if you guys don't have any additional questions. So this was a fun one. That was a submandibular mass. And I actually see a epithelioid population with a lot of background lymphoid cells. And so are we really in the submandibular gland? Or are we in a lymph node? Or is it a Wharton tumor? You tell me. That doesn't look like a Wharton tumor, right? That's too nasty, too ugly, not oncocytic enough. There's a lot of apoptotic debris. Does anybody want to stain? Or should I just tell you what it is? All right, so you may Eber. Okay, so you're thinking about a non-keratinizing squamous cell carcinoma. Excellent. This is P16. So yes, so when you have a non-keratinizing squamous cell carcinoma, like lesion in the salivary region, you're always going to want to work it up for a virus, whether it be EBV or HPV. This is one of the rare cases of a P16 positive HPV. So this had HPV 16 DNA. So this was in fact a metastasis, an oddly high metastasis of an oropharyngeal carcinoma to the submandibular region. Usually these are lower, level 2, 3, but it could happen. We've even seen really bad oropharyngeal carcinomas invade just out into the parotid area and have direct invasion of an HPV cancer out into the skin, right? We can see them metastasize. So yeah, so this will be a quote unquote lymphoepithelial, probably now referred more specifically as non-keratinizing squamous cell carcinoma. But yes, EBV and HPV should be executed in the workup of these to potentially find a source of primary. Awesome. Okay, so the next case is good. I think this is the last one. Cool. So we're doing all right. I'm going to take a couple minutes over. So here we have a core of now we're back in the parotid. Okay. Now we're back in the parotid and we see a lot of this desmoplastic stroma. We see these infiltrative nests. We see these large nests with almost some eosinophilic globules. Again, kind of infiltrative, maybe are those vacuoles? You can type in the chat what stains you want and I can tell you if I have them. We did a lot on this case, it's fine. I might not have them all scanned, but I can certainly tell you what we did. So very cellular, a little glob right there. Katie wants a P40. Katie might be in luck. Here we go. Diffusely strongly P40 positive, at least in the epithelial clusters and nests, not so much in the spindled stroma. CD99. May I ask what CD99 for? I don't know. I tend to really focus my CD99 when trying to work up a Ewing's. Because CD99 could be positive in other epithelial carcinomas, right, that are not Ewing's. So I don't think we did it in this case. And I'm not even sure what the result would be. I'm sorry about that. Androgen receptor in this case would be negative, right? And it kind of makes sense because you wouldn't expect salivary duct to have this diffuse strong P40, P63. Adamantinoma like Ewing family tumor for CD99. Yeah, so certainly as a consideration of a metastasis from a sinonasal, I don't know, do they occur primarily in the parotid? You have to tell me. I've never seen one. Maybe. Right, because those could certainly be keratin and P63, P40 positive. Unfortunately, we did not do a CD99 in this case. All right. NKX negative. You guys are thinking awesome and outside the box. I love it. With such diffuse strong P63, P40 in a parotid, do you want to think about mucoep? Even if you don't see mucin on H&E? I do. So here's a mucin stain. And, you know, other than combing through this with a fine tooth, I'm going to tell you there's no obvious intracytoplasmic mucinous vacuoles here. So this was a consult. So we got their light green. Our lab has mucicarmine and it has PAS diastase. I tend to do both because sometimes one is better than the other. However, in our lab, I actually like the PAS diastase because I think it's cleaner and stronger and you have a control, right? So if you aren't certain if something is glycogen or mucin and you have expression with the PAS or you have staining with the PAS and it completely goes away on the diastase, then you really know you're dealing with a glycogen type of substance in like a squamous cell carcinoma, for example. So I tend to like the PAS diastase. Our stain works very cleanly and strongly. And again, it'll help you with the diagnosis of glycogen as well. So yeah, so we have a diagnosis of just a plain old squamous cell carcinoma, potentially. And so I believe on core biopsy, this was called, high-grade carcinoma with squamous differentiation, see long comment. But the point is, it's an infiltrative lesion. It seems to be high grade. There's a lot of desmoplasia. So, that's what we want to get across. And here's the resection specimen. So you can see that the skin itself overlying the parotid is uninvolved. There's a nice negative zone of fat. You can see the tumor here as it sort of touches the parotid and sort of muscular tissue at the bottom, right? So this is, right here. Here's that slide of H&E showing you again that there's a negative zone between the skin and the tumor, but recapitulating that, arguably high-grade pleomorphic morphology with, let me just go down and show you how it is involving, infiltrating. Is it arising from? I don't know, but it's certainly encountering, right, the parotid glandular tissue here at the bottom. So, what do you want to do with this? I don't know if you guys still have to answer my question of if the adamantinoma-like Ewing's can occur primarily in the parotid, or if you would consider this in that differential diagnosis to be a metastasis, because honestly, I don't know the answer to that question. So all you experts out there, if you want to respond, you can. All right, so might be metastatic SCC. Does patient have a history? So in this case, the patient does not have a history of a cutaneous primary squamous cell carcinoma. But that doesn't mean anything, because a lot of old, I don't want to sound, rude here, but honestly, it's a lot of old white men that have spent time in the sun, that maybe have been outside for their work, that maybe had stuff taken off, oh, they took a little thing off. I don't know what it was. Okay. I'm not trying to be rude, but I'm trying to say that this happens a lot. And so people have skin cancers that either they don't know of or that regress. And so mammal 2 negative. Yep, mammal 2 negative. So when we don't know, we like to go through genetics. Actually, let me answer your carcinoma X question first. And so 1, this patient never had any prior tumor in this area ever resected before. So when you're thinking about carcinoma X, there are 2 ways I like to make the diagnosis. 1, did the patient have a tumor resected here in the past and now there's a malignancy? Then we have to think our way backwards. Or is there a concurrent something that could be either an active or a burnt out pleomorphic adenoma that has an infiltration around it? Generally, at least in my experience, and you can tell me if yours has been the same, generally for a perfect carcinoma X, there's like some kind of burnt out, usually hyalinized nodule that's very paucicellular, and then like, I guess I like sound effects, infiltrative neoplasm high grade around it, right? And so in the absence of a prior resection in this area, and in the absence of a hyalinized burnt out PA, I tend to not favor carcinoma X because there's really no evidence that a PA was ever there, if that makes sense. So in this case, there was no hyalinized nodule, there was no prior resection. Yeah, so okay, we're gonna rely on our genetics. In this case, the person who said metastasis is actually correct. So regardless of whether the person has had a cutaneous history or not. If a carcinoma looks squamous or squamoid, you cannot prove that it's mucoep. You cannot prove that it's EBV or HPV. Think about a sun exposed. So this had high mutational burden, high prevalence of C to T or CC to TT, which when mapped along the COSMIC database showed high signature 7, which is ultraviolet light, right? So really no primary parotid neoplasm is going to have a UV signature because these are just too deep. All of the other primary parotid neoplasms we've sequenced, right, don't have UV signature, but pretty much any cutaneous primary does. Squamous, melanoma, etc. Okay, so this is pretty significant for metastatic cutaneous squamous cell carcinoma primary, metastasizing to probably an intra or periparotid lymph node and then just blowing out. Okay, so this is not uncommon, especially in older patients who may or may not have a history of primary skin, but probably have some kind of sun exposure in their past. Okay, so UV signature is helpful. We haven't gotten into the non-squamous types of carcinomas like clear cell, for example, of salivary gland. I will caution, if you have a carcinoma that is, you know, diffusely strongly P63 high molecular weight keratin positive, right? Like we talked about, that's maybe not a mucoep, that doesn't have any duct-like structures, right? So isn't an epimyoep, that doesn't express any of the myeloid markers like SMA, S100 that you might see in a myoepithelial carcinoma. But if you have something that is immunophenotypically essentially identical to squamous, you might want to think of a formerly hyalinizing, right, but just clear cell carcinoma of salivary type that generally tends to be a little lower histologic grade, have like wrinkly nuclei, sometimes have clear cytoplasm, but sometimes have pale eosinophilic cytoplasm, stains like a squamous, but has, as you know, the diagnostic EWSR ATF gene rearrangement, right? So just, I like to say clear cell carcinoma is like the squamous immuno buddy, right? But the genetically can be proven different, all right? So as I said before, this was certainly not comprehensive with all of the salivary gland tumors, but it sort of got you thinking about these various pattern groups and how you can consider them. I believe I have, yeah, if you have the link to the path presenter, I did put, there it is. I did put Katie and I's paper in here if you want to download it. It's also available online. Something is in my way here. Hold on one second. Yeah. So thank you. Whoa, I don't know what I'm doing. There we go. Thank you to Katie for her help with this project and all of these virtual slide acquisitions. Thanks to Jason and Justin for inviting us to do this paper. And I thought it really rolled very well into this talk that just happened to get invited to do this week. So I think that's all I have. And if you guys have questions or comments, I'm really happy to take them. But that's all I have for now.
Thank you, Nicole. That was excellent. But before we're going to express thanks, but can we have some questions for Nicole? If you can use the chat function, please. Nicole, you will have access to the chat as well. And so guys, we have opportunity, so please type away. While we're busy, Nicole, tell me, you have access great to the molecular and so on. Is it standard practice for you to send it, or is it only the cases that you say you really need that to help you? Or is it becoming more and more a sort of a standard diagnostic approach?
Yeah, so I have kind of a twofold answer to that. One, it is becoming much more standard and much more heavily utilized even than 5-10 years ago. We do use molecular, one, in diagnostically challenging cases where we don't have a great, let me rephrase that, we don't have a lot of FISH probes. So if we are looking for like we're very confident it's a very specific fish, ETV6 NTRK or something, we will send those out. But we do have an excellent next-gen sequencing lab. So sometimes if we either are just sort of probing broad spectrum help, we'll do sequencing, which will pick up our point mutations and our fusions. So we are using that in diagnostics. Secondly, our clinical team is very interested in also requesting the sequencing in pretty much any high-grade carcinoma or any metastatic carcinoma to look for targeted, targetable mutations. And so we use it quite a lot. I would say for a run-of-the-mill diagnostic cases, no, but anything that's diagnostically challenging or clinically bad, yeah.
Okay, thanks, Nicole.
Yeah.
But there's a question from Leon that you can see on AskQ 61R.
Yeah, so we don't have that stain. So we don't have that stain. So I honestly can't answer it. If anybody out there in the audience has experience with that stain, please pipe up. But based on the literature, the RAS stain will or might pick up the Q61R mutation in the other RASs as well, right? So NRAS, HRAS, KRAS, it's potentially a pan-RAS Q61R pickup. I'm just actually going to stop my share because it's kind of annoying here. So I haven't used it, but it's thought to be good for all of those RAS mutations. And if the carcinoma is mutated, theoretically, it should pick it up, but I actually don't have experience with it. I mean, I'm interested in it both for the salivary, as well as you can probably imagine, for thyroid. So I honestly don't know. Yeah, so there's a second question on that same stain. Anybody out there, please pipe up. Sebaceous differentiation. Yeah, so sebaceous differentiation, as you know, so let me start with sebaceous. Let's move on to squamous. Let's also say mucinous, metaplasia, right, can happen in pretty much any salivary gland tumor. And I would exert a lot of caution when you see those types of cells in your salivary tumors, because they, more often than not, they're potentially metaplastic, and you don't want to shift your thought process too much when you're just dealing with a metaplastic phenomenon, but it can be very challenging. And so we've had very rare, truly like sebaceous lymphatinomas that are like sebaceous and lymphoid, circumscribed, bland, right? Outside of that, metaplasia could happen in epithelial myoepithelial, pleomorphic adenoma. So other than saying, yes, it can absolutely happen, and look at your surroundings, might be the best outlook. Adenosquamous versus mucoep. Yeah, so, okay, hold on one second. Neil said RAS staining works well, even on cytoblock specimens, but only Q61R, distinct pattern sparing epithelial complexes. Cool. All right, awesome. Thank you for that. So adenosquamous is a tough one because we actually just had something like this. So, when you think about what is adenosquamous and where do we know it can occur? We think it can occur in the lung. We think it can occur in the sinus as a potential association with an HPV, right? HPV-related adenosquamous. And so, honestly, that's very hard. I think if you don't have access to genetics where you are trying to look for a mammal and you see something that's, glandular squamous, I would look for morphology that is more characteristic of mucoep with intermediate cells. I would look for grade, right? Because if you're saying something is a high-grade carcinoma with squamous and glandular differentiation, one, you have to think about, could it be a metastasis from some other site like lung, in which case TTF1 may or may not help. And then you have to decide, okay, if I can't determine it's a metastasis, really more importantly, is it high grade, right? And so honestly, for me, the bottom line with a lot of this stuff is it a metastatic and is it high grade? Because honestly, that's going to drive clinical therapy, even if you don't have rearrangement, ability to detect those rearrangements. But yeah, I would say we just had a cutaneous metastasis from skin to parotid region to neck region that recurred and now looked adenosquamous. I was like, so we're going to do sequencing. We're going to sequence the original primary and we're going to sequence this now new thing that looks adenosquamous to see if they're the same thing. But honestly, it can be very challenging without ancillary techniques. If you are in a limited setting, I would say my panel would always be a P40. So honestly, if you don't have P40, please get it in your labs. Just skip the P63, go straight to P40. And I would argue some other epithelial marker like a C-kit. And then, like we said, maybe an S100 if you're dealing with a P40 negative neoplasm. Those are honestly my top three, and that will get you very far. In a simple setting, a mucicarmine PASD can certainly help you with mucoep. But like we said, there could be mucinous metaplasia and things. So P40, C-kit, and S100 are probably my top. And then intercalated duct hyperplasia as a precursor to epithelial myoepithelial carcinoma. That's a tough question. One, I think both are extraordinarily rare in routine practice. I don't have a great answer to that because I have not seen cases in which there is a direct, obvious transition from the hyperplasia to the carcinoma. But again, if any of you have experience out there with it, please do pipe up, because I think these are very rare and very challenging cases. I think more often I see challenges between diagnosis of like a pleomorphic adenoma and an epithelial myoepithelial carcinoma, or a myoepithelial carcinoma X pleomorphic adenoma. Morphologically, these are the things I think are very challenging, but intercalated duct hyperplasia I think is extremely rare. Unfortunately, I can't really comment very much on it. I apologize.
All right, that seems to be it.
Cool.
Okay. Yeah, Nicole, again, before I thank you, just again, my apologies to our US colleagues. I won't make that mistake again of assuming daylight saving is only happening at the end or the beginning of the month. But you will find the recorded link, I think, on the address and chat that Nicole said, so it will be available there. Nicole, from my side, thanks a lot. It is not very frequent or common to find a very knowledgeable person with the ability to transfer that knowledge. You really have a passion and a talent for that. And we, as a worldwide audience today, we're the beneficiaries of that. From our side, thanks a lot. It has been really an honor for us to host you in this series. We will definitely pick it up again and to ask you again in the future, because such talent and such opportunity cannot be missed. So from our side, thanks a lot. And to all the colleagues, this will be our last presentation of this year. For those having nice summer breakaways, enjoy the period, enjoy the Christmas festive season with your family and loved ones. And we'll pick up this series again early next year. So keep an eye open on the invitations. Again, Nicole, thanks a lot. Much appreciated. And thank you for being up early so that we didn't miss that opportunity.
No worries. Thank you really so much for inviting me. It's always a pleasure. And hey, I was up. I just had just 10 minutes instead of an hour. No worries.
It worked out well. Thank you.
No, thank you.
Thanks, everybody. Have a great evening.